found evidence of anti-tumor effect, but we know that MEK inhibitors don't have the same activity that BRAF-MEK combination treatment does. This particular combination doesn't seem to be hitting the same hurdles that venurafenib and ipilimumab did in their early phase 1 investigation. The rate of severe toxicity really quite comfortably low level in this particular study. And as you're well aware, other agents, PD-1 blocking antibodies, in addition to PD-L1 blocking antibodies, are being explored, and further investigation still with CTLA-4-based combination. I'd like to close with a little bit more of a understanding of the divergence of biology when thinking about MAP kinase pathway targeted therapy as the obvious backbone to explore based on clinical grounds, yes, but I would say scientifically now, increasingly we believe that's the targeted therapy regimen for the moment that we would put the most attention to in targeted immunocombination strategies. We are learning more and more about not only the genetic wiring of these cells, but their epigenetic regulation as well. It can vary within the same tumor. There can be heterogeneity in terms of the population of cells and where they are on the differentiated to undifferentiated axis. And under selective pressure of therapy, we are learning more and more that we can either prune out one of the populations and enrich for the other, or perhaps even shift the state of tumors under selective pressure of targeted therapy. So we have this MITF high state that we think might actually be the most favorable setup for an immunologic intersection. But what's emerging over more and more time is that a MAP kinase pathway resistant subpopulation can be MITF low. And these express neural crest markers. They lack melanocyte lineage antigen expression and may not be at all a state that can be recognized and respond to immunotherapies, at least in their current form. So one needs to keep an eye on this emerging biology to understand that it may be that some tumors go the wrong way, not the right way in terms of potential combination. We know from data that preceded the introduction of effective MAP kinase pathway targeted drugs that looking at human tumor samples, you can see representation of these dual populations, MITF high or MITF low, and an admixture of them in some patients' tumors. So this might become the type of diagnostic strategy we need to think about deploying in some of these studies to understand, even before treatment has started, what is the state of differentiation. Interesting data is emerging regarding the underpinnings of resistance to MAP kinase pathway targeted therapy, and I won't belabor that point now, but it does appear that the low MITF state relates to upregulation of receptor tyrosine kinases. In this study, it was AXL that was upregulated in this unbiased exploration, and it seemed to denote a companion biomarker that had an inverse relationship to MITF expression. Daniel Pieper's group has suggested that it's in fact coordinated expression of multiple RTKs that happens as a consequence of the low MITF state. So this seems like a phenotype or a state of differentiation that we could fingerprint at the molecular level. We may need different therapies to actually treat directly this low MITF population that may not be susceptible to immune therapy. So if we are thinking about strategies that would be tailored to different subpopulations, it may be that we have the MAP kinase pathway immunologic combinations that are relevant for the MITF high tumors at baseline or ones that become high on therapy. For the low group, we may need different treatments. And this very interesting report, which is the one I'll close on here, suggests that in fact, in an unbiased screen, you can understand the wiring of this MITF low state to suggest that it's in fact JAK STAT signaling, JAK1 specifically, that seems to connect to the RTK upregulation phenotype and therapeutic resistance to MAP kinase pathway targeted treatments. So in MITF low tumors, we may in fact have to think about unique strategies to try to poison that subpopulation. This could be a sequential approach for a residual subpopulation that remains after a MAP kinase pathway targeted strategy in combination with immune therapy. So we have a long way to go. I would say that at the moment, we still need to have a very steady focus on the issue of predictive biomarkers that will support which patients should get the available backbones without worry of participation in clinical trials in combination. Admitting that we're not there yet, it's reasonable at this point to include patients, continue to annotate them at the genetic, and as I've suggested in this data, beyond genetic molecular characterization to understand as we develop these data sets which subpopulations of patients are represented in those who seem to derive benefit from these early attempts to combine targeted immunotherapy. Ultimately, we would like to gain that knowledge so that when we're thinking about conducting randomized trials to confirm an early signal, it's done in a stratified fashion. We do not want to create combination regimens, inherent combination toxicities as a one-size-fits-all strategy. That it's ultimately not going to serve us in any environment. Increasingly in the US, we're asked to consider cost in a way that's bringing us a little bit closer in alignment with our European and Australian colleagues. So we're more and more sympathetic to that mandate. Thanks so much for your attention.
To address in 15 minutes just the whole of biology. I'll give it a go. These are my disclosures. So it's very clear that we do have to fit new agents in. Keith's alluded to some of the issues around resistance to the existing backbones of treatment. But one of the problems we face is that classically new agents are trialled after exhausting therapeutic options, and that has some implications for the sorts of drugs that we're likely to develop and exclude from development if we continue to stick to that old saw. We do have to acknowledge that the cure remains the exception for our patients, and for that reason it's imperative that we arm ourselves better. And the natural history of the disease, particularly in certain subpopulations, means that I think it's entirely reasonable that we can get new agents in very, very early in treatment before starting, and even in amongst the standard treatments, before starting to place them more precisely amongst the various schedules that are available to us. And we should recognise that for all the stellar data that we've seen in the past 24 hours, summarising the state of the art, the very exciting, advancing state of the art, we've got some pretty tricky populations out there for whom all of this is largely bypassed. For example, patients with symptomatic brain metastatic disease, those patients with uveal melanoma, and so forth. So bearing that in mind, what are the key considerations in bringing a new drug into this space? Well, I think the first question is whether it's designed on its own to have activity or predicted to do that, or whether it's designed specifically to embellish existing approaches. For example, the JAK-STAT inhibitors that have activity in myelodysplastic disease, one doesn't countenance using them as single agents in melanoma, but clearly Keith's articulated they may have a role in a specific situation. Some of the approaches, particularly if they're limited by logistic considerations and CMC considerations, will seek out specific patient populations, and that's particularly true for the injectables that are now being developed off the back of the exciting developments with TVEC. And the evidential base for combination and single agent approaches is required. And I think here we face a formidable problem in that there's a lot of noise, there's a lot of clamour for combination with existing agents on the basis of drugs of previously dubious activity that are now pointing out that if only they could be partnered with that exciting new checkpoint inhibitor, that would overcome their astonishing lack of activity back in the 1990s. So there's a real issue about what the evidential bar should be to access to the clinic. Now, if we look at the BRAF and MEK inhibition story, then very quickly after BRAF treatments emerged, papers of ever-lessening impact, reflecting the burgeoning field, described the mechanisms of resistance, and this led obviously to the dual node approach of BRAF and MEK inhibition, and now a similar story is playing out around how we overcome those tumours that are resistant to that combined approach. One example of that is the Logic 2 trial that Reinhard described in his presentation yesterday, where patients receive encorafenib and binimetinib, have a molecular evaluation comparing a progressing lesion with the primary or prior to treatment lesion, and have the addition of one of four drugs, including a CDK4 inhibitor, a PI3 kinase inhibitor, an agent targeting FGF or MET, on the basis of that molecular evaluation. I think it's an exciting approach, it's an innovative approach, and I suspect, unfortunately, it's likely to run into significant problems that mean that the answers that we gain from this aren't necessarily optimal. And that's perhaps best illustrated in this slide, which is adapted from one by Georgina Long, looking at what happens with combination when you use it up front, or when you use it, if you look at the right-hand side, the waterfall plots in particular, and at the bottom too, in comparison with when you use it after progressing on a BRAF inhibitor. The response rates, the median survival, are much inferior in that second circumstance, suggesting that adding drugs at the point of resistance may not be the best way of getting what one can out of a particular approach. And the question then becomes, with a trial like Logic 2, what can we learn from that that might allow us to apply those therapeutic interventions earlier, whether it's at the start of treatment or soon after, by molecular analysis, rather than waiting for the point of progression in order to define how we modulate our therapy. I think that's also illustrated by the TVEC experience. Now, obviously, we had the news relatively recently that the FDA have approved that, along with the positive CHMP analysis by the EMA. So this is going to enter the standard therapeutic armamentarium. Now, had this been a resistance modifier or a later line of therapy, it would have failed. Because if one looks at the forest plot, and I take people's reservations about post-hoc analyses of subgroups, but there's a very clear distinction here in terms of the hazard ratios for progression-free survival and overall survival, which favours the use in the first line, which favours the use in patients with less advanced forms of disease. And the drug development strategy that's bolted onto the back of failure of existing regimens isn't going to unearth something like TVEC. Now, one could argue that if it isn't going to do that, then maybe it's not of sufficient quality to meet what's going to be the ever more substantial financial bar to drug development in this space. But I think it illustrates an important point that we must go early in the disease with novel interventions to get a true estimation of their worth, allied to translational research that makes us understand what the true value of that is likely to be. So we've got significant areas of unmet need, and one area in which we can obviously develop new drugs is in those that are poorly served. And in particular, obviously, one does have the progressors on the established agents, but patients with symptomatic brain metastases, particularly if wild type for BRAF, have a significant unmet need, as do the rarer forms of melanoma and the NRAS population within that wild type BRAF group. I'm not going to dwell on those, though, significantly. I spoke about NRAS yesterday. Axel is talking about it later, and others are going to talk about some of these areas as well. What I'd like to do, though, is to try and illustrate some of the challenges that we face by looking at immunotherapies and all of the potential new drugs coming along, as listed on this slide, that could be applied with the existing checkpoint inhibitor backbone. Now, clearly, there are very, very many of these, and the question becomes, how do you choose who to give them to, which drugs to prioritize for development, and to bring through to the clinic. And what I'm going to do is, just by way of example, rather than try and wade through that morass, talk about IMC GP100, a drug whose development that I've been involved in, as have others in this room, and essentially how that story has played out and what that means in terms of its ongoing drug development, because I think it illustrates a couple of those points. So IMC GP100 is an ImmTAC. It's got a modified T-cell receptor with very, very tight affinity for GP100, presented by HLA-A2, picomolar levels, and it's bound to a CD3 fragment at the other end, which binds onto T cells. And its mechanism of action means that it targets peptides rather than full proteins, which gives it a point of distinction over existing antibody approaches such as CAR-Ts, bispecifics, and antibodies. And it provides very, very tight binding between the cancer cell and T cells, and this results in an immune synapse and apoptotic cell death by injection of lytic granules, as one might anticipate. So over the past 3 years, we've conducted a dose escalation phase 1 study, the results of which have been presented previously at AACR. We established dose-limiting toxicities of hypotension associated with rash, fever, and edema, all of which are consistent with the mechanism of action of an immune-active drug likely to cause significant cytokine release. And then we've expanded that to look at a larger group of melanoma patients, often with prior treatment, although perhaps reflecting the UK bias for this study, not as much prior treatment as one might anticipate in the North American population. and shown some promising activity in a couple of these responders here at the bottom of the spider plot in patients with uveal melanoma. And this is also shown here with the waterfall plot. What we see is that the response rate seems to be around somewhere around 25 to 30%, although this is early days in small numbers. We've seen responses in patients who've been refractory to ipilimumab and to pembrolizumab, and it seems to be independent of GP100 staining, which I think says more about the accuracy of the test rather than whether GP100 is required for targeting, which clearly it is on the basis of the modified T-cell receptor agent. What we've also seen from our translational research is that we get an influx of T-cells into the tumour very soon after dosing, which is lost over time. It seems to recede to the margins of the tumour, as shown in the top 3 slides there, pre-dose, day 3, day 52 after the 8th dose of IMC GP100 staining for CD3. And this is also associated with PD-L1 staining and HLA-DR as well. So what we have is a new agent, single agent activity, a mechanistic basis for synergy with existing treatments, such as PD-1 inhibitors, looking at Paul Tumay and Tony Rivas' work in that area. And what I haven't shown you today is confirmatory preclinical experiments backing that up and suggesting that a combinatorial approach is justified. So, how does one place this amongst existing therapeutic options? Well, clearly, one can consider it as a single agent. One can use it in parallel with existing checkpoint inhibitors to augment their response and give it up front, or one could use it in a way to overcome resistance to patients who've already been exposed to checkpoint inhibitors and progressed, which is a pretty tough bar and has some problems, as shown by the experience by extrapolation, I admit, with the targeted agents. The actual plan for developing IMC GP100 is on the website for the company involved, so it's in the public domain, and essentially is a hybrid of all of those approaches. So the uveal melanoma population clearly has unmet need, does not appear to be responsive to checkpoint inhibitors or to ipilimumab as the cutaneous melanoma group, and therefore justifies a single agent approach, which will start next year with IMC GP100. Insofar as cutaneous melanoma is concerned, the priority is to combine this on the basis of the mechanistic effect of the drug and on the preclinical evidence of synergy with PD-1 targeted and CTLA-4 targeted agents. In this case, AstraZeneca Medimmune's durvalumab and tremelimumab. So a phase 1 moving into phase 2 expansion program will start later this year, early next year, looking at combinations with one or both drugs, both up front and then to address the resistance question in prior PD-1 targeted agent progressors in order to ask all 3 questions. And I think that sort of combined approach is sensible and gives us the opportunity within a few dozen patients to establish what the potential role might be of this drug alongside existing therapeutic options. So, in summary, where we are now as far as introducing new drugs into the field is concerned is that the evidential bar for clinical development is now higher. The old saw of trying to get a 20% response rate as the cut-off for preliminary efficacy, I think, is gone. We demand much higher standards. We're interested in tails of curves. We're interested in progression-free survival. We're interested in exceptional responders, not just in response rates. Despite that higher bar, the potential combinations that we have for testing are far too great for the available population to support. Now, it could be argued that we're moving into an era which has significant similarities with breast cancer, but there they have the advantage of many, many more patients to choose from, so that even with selective approaches, even with multiple lines of treatment, there are still dozens of patients available for clinical trials at any one time, whereas that's simply not the case for our population. And we are going to have to move, I think, to adaptive trial designs, ideally with shared control arms, to sift through promising regimens and to prioritize those for onward development. And that requires a maturity in terms of the field, which I don't think we're there with yet. There are too many agents jostling for position at the moment, too many unanswered questions. But within a few years, as these bed down, I think the opportunity for adaptive trials such as the I-SPY design and battle that's been used in other tumour types such as breast and lung will become available. So with platform trials, obviously one has multiple randomizations and cross comparisons. I do apologise for the way in which that's appeared. Adaptive randomization essentially allows us preferentially to allocate patients to better performing regimens until such time as they graduate to go into separate definitive testing for regulatory purposes. It allows us to compare first-line therapies in a standard way, pairwise as opposed to totally across the study. It allows us to compare second-line treatments, whether that's independently across all patients or second-line after a particular first-line approach. I think it also allows us to look at different sequences within the trial. So they have the potential to be quite powerful if they're of sufficient size and rigor. So in summary, we've got now a much higher bar for clinical development than we've had previously, and I think that's very much for the best because it means that we ask ourselves much tougher questions. The first 15 years of my involvement in melanoma were perhaps a triumph of optimism over reality because our evidential bar for going into clinical and indeed into phase 3 testing was far too low. Because of the wealth of combinations available to us, we are going to have to think of different ways in which we develop these drugs and look towards adaptive designs in the future in order to make sure that we don't miss out on potentially interesting combinations simply because they don't have the financial muscle or shout loud enough for our attention. Thank you very much.
Thank you very much, Mark. This was really an exciting talk and also brainstorming with us. In the interest of time, we'll have a panel discussion at the end in these nice sofas here in the middle of the podium. And we'd like to continue with the next presentation by my co-chairman, Paul Lorigan from the UK. Paul, which is a topic of...
What I'm not going to do today is give you an overview of mechanisms of resistance to targeted therapies. I'm going to focus primarily on targeted therapy and mention just one slide on immunotherapy. And what I'm going to try to do really is just to flag up the concepts that are arising from this discussion about retreatment with targeted therapy, and really just to think about the implications for patients, for payers, etc., and for clinical trial design. So this sort of, started thinking about this. I had a patient, 45-year-old female who had a low-risk melanoma moved in 2007 and then developed stage 3 disease, high-risk disease in stage 10, 2010, 11 of 13 nodes positive. She had a BRAF mutation, V600E mutation at that stage. And then in 2011, she represented with metastatic disease with lung nodules and brain metastases. And we treated the brain mets with stereotactic radiosurgery, and she went on to the vemurafenib safety study. And in fact, she had over a year of benefit with vemurafenib, and then she progressed in her brain and in her lungs, so we gave her whole brain radiotherapy, and she had ipilimumab, and surprisingly, perhaps, she responded in her lungs and in her brain, developed hypophysitis, so had significant toxicity with the immunotherapy. And then, nearly 18 months later on, she progressed again in her brain and her lungs and new adrenal metastases. And I sort of scratched my head at that stage and wondered what to do with her. We didn't have access to an anti-PD-1 at that stage. We were able to access the combination of brafenib and trametinib, and we restarted that. We started her on that, and she responded in all areas, and again, had nearly 18 months of, or 15 months of benefit from that, and now she's progressed again, and she's now on an anti-PD-1 antibody. So, looking back at the literature, there are a number of case reports looking at retreatment with BRAF inhibitors. There's a study from Emanuela Romano and colleagues looking at one patient with 2 metastases that they sequenced. The patient had initially responded, then progressed, and what Emanuela showed was that there were 2 different mutations that were identified in the progressive tumors. Another small series, again, looking at patients, 9 patients and 2 patients But what's interesting here is there is a significant clinical benefit for those patients. So why is this then? So, many years ago in medical school, I was taught about the Goldie-Coleman hypothesis, and that tumors accumulate mutations over time, and this will, or they acquire mutations, and this means that they accumulate drug-resistant mutations. And then if you add in a bit of Darwinian selection by treating the patients with a drug treatment, then you will select out perhaps the drug-resistant clone, and that will lead to drug resistance and progression of the tumor. Or it may well be that there was a drug-resistant clone there all along, which was imperceptible initially, but then you select it out. And that was our sort of concept of resistance to tumors. But in fact, when you think about it, there are a number of different models that as oncologists we've been used to dealing with. There's the treatment re-challenge, and this is well established in many solid tumors, ovarian cancer, small cell lung cancer, where you treat patients for a period of time and then you leave them off treatment, and then they perhaps progress again after 6 months, 9 months. And those tumors were not resistant at the time. They had reduced in bulk, but they were not resistant. And we've got the majority of those patients, depending on the disease-free interval, will respond to treatment. So you didn't stop treatment because of resistance, you stopped treatment because you were treating patients for a set period of time. And then the other group that we've looked at is treating beyond progression. And there are examples in other cancers, in breast cancer and colorectal cancer. But clearly, and Mark showed it earlier, the case of adding in a MEK inhibitor in patients progressing on a BRAF inhibitor. And Keith, this doesn't project very well at all, and I apologize for that, but it's a randomized phase 2 study. And it clearly shows that adding a MEK inhibitor in patients progressing on dabrafenib was associated with a very modest benefit, really, and is not the best way to treat these patients. But that's not what we're talking about here. What we're talking about here is treating to progression and then switching to a second treatment and then re-challenging those patients after a period on a second treatment, and a proportion of those patients responding. And the question is, why is that? So is there some form of reversal of the resistance? Is the resistance phenotype transient? Or do the resistant cells have a fitness deficit that allows them to flourish when they're being treated, but when that is removed, that other cells grow back in their place, that they're less vital? And if you look just at other tumor types, then there are examples of where this has been done. I've just picked one study, gastrointestinal stromal cell tumors. The right study, it's always good to pick a good acronym for your study. And these were patients who had progressed on imatinib and then had been treated with sunitinib, and then on progression with sunitinib were randomized to either placebo or imatinib. Now, there was clinical activity here seen. The response rate was 22% on re-challenge, and there was a modest benefit, but it was clinically very minimal, really, in terms of progression-free survival, disease control rates, and overall survival. So there is a precedent in the literature. And then looking at, are there any preclinical data? And this is a slide from Grant MacArthur, and I'm very grateful to Grant for this. And this was presented at AACR. And this is looking at, this is a cell line, WM2664 melanoma cell line, treated with vemurafenib, or our control is the black line, where they were untreated. And the red line is treated for 5 weeks. The blue line is treated for 4 weeks, and then the vemurafenib withdrawn for a week. And what you can see is that by withdrawing the vemurafenib for a week, the sensitivity returns to the cell, to the cells, so they become more sensitive to BRAF inhibitor than if they'd been on continuous treatment, but not as sensitive as if they had never been exposed to treatment. So a suggestion that there is some form of reversal of resistance by discontinuing treatment. And then a very interesting study in colorectal cancer, looking at, this was 10 colorectal tumors which were passaged through serial mice xenografts. And they were able to, with lentiviral marking, they were able to follow these tumors And what they were able to show was that clonal stability was maintained throughout the tumour passages. So, but when they looked at the vitality of these cells and the resistance to treatment in terms of chemotherapy and the potential for repopulation, what they saw was that this varied very much across the different models. And the suggestion here is that despite the sort of maintenance of genetic stability here, there's a sort of functional heterogeneity within these xenografts, which is, well, they don't explain, it's not explained why that would be, but it's likely to be in some way related to maybe epigenetic phenomena or something like that, which would modulate the resistance or ability to metastasize. And so this comes on to, and Keith touched on this concept, and this is Daniel Paper's paper recently, about sort of phenotypic switching, where you have cells that can sort of transfer from one, or move from one phenotype to another, and here they describe moving from a sort of proliferative, more differentiated tumour, which is rapidly growing, but more sensitive to BRAF inhibitors, which is a high expressor of MITF, and then to the undifferentiated, less sensitive tumour, which is more likely to metastasize and is associated with downregulation of MITF and upregulation of inhibitors of the Wnt pathway. And this concept that cells have this plasticity, that they can move from one phenotype to another depending on exposure or lack of exposure to a drug, may well explain why not all, we haven't found sort of molecular or genetic explanations for why all the resistance mechanisms to BRAF inhibitors. And again, another slide just from Daniel Paper's group, and this was and the NKI group in Amsterdam, and this was looking at one patient, and they cloned, they did mutation analysis on a number of different metastases in this patient who was treated with a BRAF inhibitor. But the interesting thing is that this patient developed a MEK1 mutation, and if you look at where they were growing the cell line and treating it with vemurafenib, I think what you can see is that the cells with the MEK1 mutation were less vital. They were harder to grow compared to the cells that didn't have a MEK1 mutation. So whilst the mutation gave it a sort of selective advantage when the patient was being treated with vemurafenib, in fact, when those cells were less vital, and when the vemurafenib when the cells weren't exposed to vemurafenib, then they had a growth disadvantage. So suggesting that certain mutations may be associated with a lack of vitality. So there are the sort of concepts around why sensitivity to BRAF inhibitors might return after a period of time off treatment. We know clearly from looking at the ipilimumab studies, and this is from the Italian expanded access program, that patients can respond to retreatment with ipilimumab. I think we have no understanding yet whether that's the case for the anti-PD-1 antibodies. So in terms of what are the implications for all of this, well, I think, we're redefining the definition of treatment resistance. Previously, we thought, resistance was the tumors progressing through treatment. But in fact, this may be a temporary phenomenon. And as Keith said, that better understanding of the molecular mechanisms controlling this may allow us to identify new treatment approaches. And this is going to have implications for patients, hopefully good implications for patients, because it may well be that we are going to start exposing more of our patients to retreatment with treatments they've had before. And of course, this has implications for service providers and also implications for payers. So what are we doing about this? At present, what we're doing is we're collecting retrospectively data on patients retreated with BRAF inhibitors, and we're looking at, just to sort of quantify this a bit better, looking at the data, the depth of the initial response, duration of response, the interval of treatment, the response to that and the duration, etc., and then what happens when you retreat. And it's a very simple data set to collect. If anybody would like to contribute to that, that would be great. I can send you, it's just an Excel spreadsheet, and we've got a number of patients already, but that's just one way to try and quantify this a little bit more. But clearly the way to do it is to do randomized trial, and this is a randomized study proposal from the EORTC, and it's looking at sequencing, and it's for patients with a better prognosis, and randomizing patients to either start with a BRAF-MEK combination, and then on progression to switch to an anti-PD-1 antibody, but on second progression to retreat with a combination BRAF inhibitor, MEK inhibitor, or the alternative to start with an anti-PD-1, second-line therapy with anti-BRAF MEK inhibitor, etc. And so this may hopefully help us to address the question. So it's not a comprehensive overview, largely because it's a poorly understood topic at present, but certainly food for thought and very sort of encouraging and positive as we go forward. Thank you.
Thank you, Mr. Chairman. It's a great pleasure to be here and to be discussing this topic of response and loss of response, and I would like to thank Jean-Jacques Rob and the EADO committee for this kind of opportunity. These are my disclosures. When we treat a patient with BRAF or BRAF-MEK inhibitor, we are actually addressing a fairly heterogeneous cell population. These cells have other alteration than BRAF, and of course one may postulate that this is actually changing the biology of response. In addition, the tumor microenvironment can play an important role sustaining tumor growth. So the question is how these are actually altering some of the proximal endpoints like response rate or progression-free survival. Once the patient is relapsing, of course we would like to do the same analysis to be able to understand how the selective pressure that we have applied with our inhibitor is reshaping the landscape and what are now the new drivers that are responsible for disease progression. And again, trying to correlate that with other markers like overall survival. Targeted therapies in melanoma have really been a fantastic success. You see here single agent vemurafenib, single agent dabrafenib data. And of course now we're moving to combination therapies with MEK inhibitors being added. You see here in blue the response rate, in orange the median survival, and this is a hallmark of this approach that there is a very high response rate, yet a limited median progression-free survival. So clearly response and escape to response is an important aspect in this question. I'd like to start by reviewing some of the data that we have for baseline alteration and using here the TCGA classification that now determines 4 groups of melanoma: BRAF, NRAS, NF1, and triple wild type. And if we separate the melanoma in this way, we could assume that, for example, the BRAF wild type gets treatment by the combo, and doing so is actually equivalent to neglecting all the rest of mutations that we see here. Is this a valid approach, yes or no? I will try to convince you during this talk and looking at specific co-alteration that I've listed here. Before we get there, I'd like just to take a step back and think about BRAF as an oncogene. It's probably one of the best described oncogene ever. It's very stable, it's early on in the process, yet it's not necessary. We have 50% of melanoma that are not BRAF wild type, and it's not sufficient. We have mouse model arguing that you need co-alteration, and we have a very nice example from the clinic. Nevi are actually BRAF V600 mutated often, and they do not progress as an invasive disease. So clearly, the associated alterations are extremely important in this context. So I would like to start by reviewing the clinical data that is associated with outcome, starting with this nice paper from James Larkin, this real-world scenario analysis for vemurafenib, looking at performance status, end stage, LDH, brain metastasis, all these bad prognosis patient group. And if you look at LDH, for example, you see that the response rate is dramatically reduced if LDH is elevated, so is median progression-free survival and overall survival. We should recall that These are also important prognostic markers, and of course, it doesn't mean we should not treat those patients with BRAF inhibitor. We actually should treat them even more aggressively as per the results of the COMBI-B and COMBI-D data. I think the MEK inhibitor is improving the hazard ratio in this bad prognosis patient population. Now I'd like to switch to the baseline genomic alteration and see how this correlates with some of the proximal endpoints like response rate and progression-free survival. And I will do that going down the MAP kinase pathway, starting with what we know about RAS. NRAS is really a clear hallmark of resistance. We have seen that in many trials, but very interesting data came out from the COBRIN study that Grant MacArthur presented at ESMO and actually yesterday here as well. And you can see that presence of RAS, RAF, RTK mutation or RAS alone does not impact at all on the PFS. It does not impact either on overall response rate. So clearly there is something important here to understand how having the mechanism of resistance in place at baseline does not impact the time you benefit from treatment. A lot of research is needed to understand that fully. Moving down the MAP kinase pathway to BRAF, clearly the type of mutation is important. V600K responds less and has a shorter progression-free survival. It's not, of course, the driver is very stable, so it's not implicated in resistance. BRAF amplification is a resistance mechanism and has also been shown to reduce proximal outcomes. And we all know that BRAF spike variant, CRAF or CUT overexpression are resistance mechanisms. Going to MEK now, again, MEK mutation are hallmarks of resistance upon treatment, but they are also now being seen as impacting proximal endpoints like response rate and progression-free survival from this work from Carlino and colleagues. And I would like here just to take a step back and look at some of these mutations. 2 years ago, we actually looked at a mutation 203 to K, and this charge reversal here is actually repelling the alpha helix, moving the kinase into an active conformation. This is the result of a molecular simulation done by Vincent Zoet in my group. If we now look at the two mutations that have been discussed with, in the paper of Carlino and colleagues, the L and the S mutation are actually stabilizing the helix, so we don't see this mechanism at all yet. The Q, the glutamic acid here, does the same as shown here. You can see that now there is a repulsion between the glutamine 124 and glutamine 46 in the A helix. So this is not the same location, yet at the end it's the same molecular mechanism. So what I would like to conclude here is that we might be able in the future to group some of these alterations together for their essential common molecular mechanism, and of course gain statistical power and understanding when we analyze trial data. So now we want to move to the non-MAP kinase alteration, starting with PTEN on the PI3-AKT-mTOR pathway. This is clearly a resistance mechanism, and here again we have had interesting data from Grant MacArthur showing that in the COBRIN trial, if you have a BRAF mutated patient with the PTEN loss, BRAF inhibitor alone is not a good option. If you add MEK, you move the patient back to the curve. So that really shows that with regard to this co-alteration, the type of treatment that you're delivering are, of course, doing a lot. And here, having the MEK inhibitor annihilate this coexisting alteration. Cell cycle is very important. You can see here a deep impact of cyclin D1, for example, at PFS, but also as a resistance mechanism. And interestingly, the microenvironment is also playing a very important role. You see here the nice work of Todd Golub showing that calves can secrete HGF, which can stimulate the MET signaling in melanoma cells, leading to a lower response rate. Whether or not this is a resistance mechanism is not firmly established, but that's work for the future. We have also other alterations. This is not an exhaustive list, so I would just to move on. Now, what about the resistant landscape? I would like just to summarize what we have learned so far. So we have receptor tyrosine kinase amplification as a mechanism of resistance, receptor tyrosine kinase mutation, or mutation at the RAS level. We can have BRAF splice variant overexpression or CRAF overexpression, and we can even have escapes that come at the MEK level with MEK1, MEK2 mutation and COT activation. So these collectively are the MAP-dependent escapes. That's reactivation of the MAP kinase. If you go up larger, you have the PI3-AKT mTOR. PI3 and AKT can have mutation. You can have also mutation in the upstream receptor tyrosine kinase or PTEN loss, as we have seen. So these are the MAP kinase independent escapes. In order to really understand how this is at play in the real world scenario of the clinic, studies of this type are very important. There, a baseline biopsy was performed and a similar biopsy at progression with whole exome sequencing, allowing to really not only find alterations that are known to be driver of resistance, but also new alterations. And this is the landscape that has been obtained from that study, showing really that NRAS, MEK1, MEK2, PI3 kinase, and PTEN are really important driver at this stage. But of course, we no longer treating patients with BRAF inhibitor alone. We are treating with the combination therapy, BRAF and MEK, and we now start to have similar data arising. This is the work of Georgina Long last year, showing that basically BRAF reactivation is a hallmark of resistance to BRAF-MEK therapy through BRAF amplification, NRAS mutation, or MEK2 mutation that seems to be playing an important role in this context. So now I would like to finish up to show you example on strategies that one can use to fight this resistance. Some of it has already been touched upon. The first one is to try to add rationally additional inhibitors. That's the logic 2 spirit. Patient have a biopsy at start, at progression on the combo, and then depending on what is the most important alteration that is observed, we will add a third inhibitor. So we are expecting data by 2017 to see whether this is a useful strategy, yes or no. Second, sequential regimen. Paul Lorigan set the stage very nicely. The concept is the following. You have a heterogeneous population that you're treating with your BRAF inhibitor, and of course the resistant cells are going to grow at escape. If you keep pushing, you're going to have more resistant cells. If you stop, then you're going to have a competition between the resistant and the sensitive cell. And Paul nicely showed that at this game, the resistant cell might not be at an advantage and actually might grow slower. Hence the idea that you might end up with a population that is more sensitive than before, which you can be subject to BRAF inhibition. So this is now going to be tested in trials, but I think the general concept is very interesting. Treatment beyond progression has been touched upon by Paul nicely as well. In this study, we tried to analyze 2 metastases in one of our patients that was progressing on BRAF. And to cut a long story short, we observed one NRAS mutation in one of the metastases and a BRAF splice variant in the other one. So clearly not a good message that you have 2 very different escape mechanisms at the same time. However, the interesting thing was that we could not find a BRAF splice variant in this tumor, and we could not find an NRAS mutation in this tumor, arguing with the fact that those resistance mechanisms are not shared, which might be a reasoning to say that keeping patients